Hello. Welcome to the Doctor's Lounge, presented by OBHealthy. We're a group of physicians, and we're here to do two basic things. Number one is to improve health of people of African descent, and that's so important to us. The second is to encourage young Black males to go into medicine because we really need them. And in the future, it's going to be even less of a presence for Black males in medicine, so we need them now. So we're encouraging young guys to, if you're thinking about medicine, then go ahead and make that challenge and become a doctor because you can do that. Our webinar is every second Saturday at 1 o'clock. And please tell others about it because, it takes a village for something like this. We're here to educate you from a medical standpoint. If you want to see our past webinars, just go to OB Healthy and click the doctors tab, and then you go to our YouTube, and all of our past YouTube webinars are right there, all different topics. Go and check them out. So important that we know more information about our medical problems. Okay. Remember to subscribe. Please subscribe so we can continue to bring this to you on YouTube. The most important thing that I can say today is please do not change. Please do not change any aspect of your medical care until you consult your physician, because only your doctor, truly, only your doctor can take care of you from a medical standpoint. Alrighty. Today, I should say, we are so privileged to be talking about emergency medicine. And we have someone here that is emergency physician. And I'm so proud that I could bring him on because he's somebody that we all know, the physicians that are on this panel, we know, and understand other physicians will be joining as time goes on. Everybody's making rounds this morning and they join as they finish their rounds. So I'm just so thankful that we're able to bring this to you, and we're able to have Dr. Trevor Dixon with us. Let me tell you a little bit about it. Let me tell you. Dr. Dixon is an emergency medicine physician. Also, he's director of emergency ultrasound and an assistant professor at the prestigious Albert Einstein Medical School. That's in, as he says, the boogie down Bronx, New York. Dr. Dixon inspires uh, and mentors students, residents, fellows in emergency medicine. This is what he does. When you go to the emergency room, you're going to see someone like him. He has a patient-centered medical approach. And that's so important because when we come to the emergency room as people of African descent, it's so important sometimes that we see somebody that looks like us and has an approach that's patient-centered. So these are some of the things that I'm so proud that I can introduce this brother, and so proud that he's with us today. Dr. Dixon, is there anything you want to say that I forgot? Because we're just happy to have you here, brother.
Yeah. Firstly, I want to thank you for can you hear me, guys?
Yeah. Just speak into the your computer. Yeah.
As a young physician, as I was, not that you guys are much older than me, but I was young to medicine. Um, I'm so privileged and humbled because all of you here, and when I say all of you, it's just so unique for me. I've been at quite a few institutions. I started at New York Bethesda in Newark, New Jersey, and I moved on to University Hospital in Newark. And also I was in Missouri for a small period of time. But everyone on this panel and everyone who comes on, including Dr. Garrison, who is at St. Michael, um, I've worked with all of you guys, and I think that's very unique for me personally. So this is a natural. I know you guys think, especially Dr. Anderson said, I know I should have been on a long time ago, but as they say in Jamaica, nothing before the time. So I'm happy to be here. I really feel like I'm part of the family, although I have strayed. The prodigal son is home, so hopefully I can make some more of these podcasts and let's get our people better. Let's get our people healthier. and let's just be there. So when they walk in the emergency room, they see that face that they can trust, and not only that they can trust, but we understand their journey, we understand their struggles. So I'm
Yeah.
happy to be here.
Thank you, brother. Thank you. Thank you for taking the time. And you're right. We are going to have to get you back here because you have a lot to contribute. Let me just introduce who's here. I know Dr. Sprock was on just a minute ago. He's having a little technical difficulty. He'll be back on in a minute. Dr. Court, can you introduce yourself, please?
Dr. Court, my practice is located in East Orange, New Jersey. I'm a graduate of Howard University in Washington, D.C., internal medicine.
Yes, sir. Dr. Patrick Anderson.
Good afternoon, everyone. Can you hear me?
Yes,
Yeah.
we can.
Yeah, yeah. I'm Patrick Anderson. I'm a board certified gynecologic oncologist, primarily practicing out of Newark Beth Israel Medical Center. Um, and it's always an honor to be on this program the second Saturday. I look forward to it every month.
Thank you very much. And I'm Dr. Omar Bey, a pulmonary critical care physician and a subspecialty in nutrition. And we are going to get started here. We're going to talk about emergency medicine, and that's important. You know, understand what I'm talking about emergency medicine. You know, when we're talking about strokes or we're talking about heart attacks or respiratory failure, when you come in, you can't breathe. This is what Dr. Dixon handles every day. You know, he never knows what's going to come through the door. But Dr. Dixon, just give us like an overview of how an ER works or what ER is all about. Can you and get us started that way?
Sure, sure. Emergency medicine is basically a new field when it comes to medicine. Many of these doctors here, probably including yourself, would have worked in an emergency room as a young doctor at some point in your life. Um, However, emergency medicine has emerged as a specialty all to itself, where um, most urban areas, and you'll see a board certified emergency medicine physician. What does that mean? It means that that physician can handle all aspects of emergency, from intubations to thoracotomies and other things that in some environments you may never see them having to do these what's called heroic procedures, but for most medical professionals who are practicing in emergency medicine in the urban areas, they would have to be, in this day and age, board certified or board eligible for certification. Um, Emergency rooms are broken down into basically three levels. You have uh, level three, which is your local um, emergency room that's maybe in a small community um, that see basically almost healthy patients, almost like a one step above an urgent care center. So in some places, then you have what's called like a level two, which is like they see a lot of illnesses. Depending where they're located in the urban areas, they see a lot more than probably what they should see. And then you have level one, which means that that facility usually have all subspecialties in-house or very closely on call, where they can be in the hospital in less than 30 minutes. So level one trauma centers are what that's the highest level, and usually all the specialties are there. Some hospitals function as hybrid level one, level two uh, hospitals, especially in the urban areas. There's a lot of crossover where this is concerned, and sometimes even some level one trauma centers will defer some patients to what is referred to as level two trauma centers because they don't offer that service. Especially
Mhm.
with healthcare, our healthcare is situated here. They're always slimming down um, how medicine is distributed, and sometimes the patients won't know that you're in a level one trauma, yet still you may be transferred, for instance, to New York Beth Israel, for instance, because they have a strong pediatric department or a strong OBGYN department. They may have to transfer some of those patients to those facilities, even though they're not considered a level one trauma center. So there's a lot of overlap. And basically, when someone walks into any of these, especially urban emergency rooms, it's not what they expect the treatment to be. In other words, most of these programs are usually linked to a residency program, which means that they see different levels of doctors once they walk in the door. They may see a more junior physician, then they may see a more mid-level, and then at the end of the journey, they will meet what's referred to as the attendant, which is the supervising doctor who's on that shift. So people don't understand that. So especially a patient walk into the emergency room, they say to themselves, why do I have to give the same information 4 or 5 times? And they get frustrated because they don't understand the structure of most emergency rooms, how different levels. First, they'll meet a nurse usually, who does the triage, and they'll ask them why they're here. And then they meet a junior physician who may ask them again the same question. Then they're frustrated already. Then they reach a third person who asks them another question. So um, unless patients understand the system, as they would say, or the hierarchy, then they can be a little bit frustrated, and you can see the frustration. By the time they see me, their level of frustration is usually through the roof. But any good physician expect that their patient will be frustrated um, by the time they get to near the end of their journey. So we, psychologically, we let them what's called vent. We let them tell us everything that they feel about us, how disgusted they are with the medical system, and at the end of that journey, after we find that 95% of them, once they're finished venting, they'll even come back and say, "Sorry, doc, I'm just so sorry, but I've been here for so long," and
Mhm.
so this is emergency medicine in urban areas, um, so that's what I do all day. And basically my job is basically we do triage basically. We look to see who are the sick amongst the sick, because everyone who walks into the emergency room believes that they're sick, So um it's important that the physicians know their population, and they have to be familiar with the culture of their population. Because a patient could just you could just look in the patient's eyes and tell that something is wrong without them saying a word, because culturally, for instance, that a black male that's 70 years old or 50 years old, 40 years old, he doesn't want to be in that emergency room for the first place. So something is wrong. So unless you're keen to understand that, you're gonna miss the boat completely. So
Mhm.
my first, and the reason why I chose emergency medicine is because I know that I'm at the doorway of medicines for many times, especially for black males. If they go to the emergency room, it's because they have no choice, or they really feel sick, or sometimes it's their partner, it's their wife or their girlfriend who forces them to come in. And sometimes you got to pull a girlfriend to the side and say, what's going on? Why is he here? And she'll tell you. He's not going to tell you, but so it's really culturally we have to know the cues of how to best serve our people. And sometimes people just don't get it because they're not really of that race, they're not of that culture. So it's important that, as you mentioned before earlier in this talk, that there's such a small amount of black physicians um worldwide, and especially here in the United States, that we're becoming an endangered species. So, what can we expect from healthcare in the future? It's going to get a lot worse, I think, before it gets better. So, we have to kind of mentor, as you said before, and we have to find those programs that are really here to serve our people. I'm fortunate. I'm in the Bronx at Albert Einstein, um, in the Bronx there, and there's a doctor. Her name is Dr. Lynn Holden, and she's a champion. She has a lot of program, a mentoring program for high school students, all the way up to pre-medical medical school, and she does a lot of mentoring in the community here and there in the Bronx, and she brings in a lot of students, not just from the Bronx but through the tri-state area. She brings a lot of these kids to these weekend programs, MCAT preparatory programs, and all that kind of stuff. So we're trying to get it done, and I'm happy, to be in the emergency room. I love being in the emergency room. It's a marathon, it's 12 hours, and not everyone is cut out for that. But with the proper training and with the proper rigor of an emergency uh, training program, residency program, um, and the love of your people, and that's what keeps you going, and that's what makes you thrive and stay in there. Just like you guys, it's the love of the people why we get up every day and we do it. So I'm happy to be in the emergency room, and like I said, I've worked at a mostly urban areas. I can't speak so much for those those quiet suburban areas, but I would say that emergency medicine is needed. Our people can access uh emergency medicine. I'm in the Bronx, and just like New York Beth and University Hospital was like, patients can walk in and know that they're going to see someone that looks like us, and and they can get the best care that they can. And sometimes it's a misnomer for our people. Sometimes they want to go far away from the urban areas because they think they go somewhere else where people don't look like them, they're going to get the better treatment. But as you know, and I know, we're the best to take care of our own. So
Mhm.
we're happy to be here.
Excellent, 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 man. Excellent. We have a couple questions coming up.
Sure.
Dr. Anderson, you've had your hand up first, please.
Yeah, so one of the great conundrum with emergency medicine is it's often seen as an access point. But what is the messaging with respect to access? Emergencies are for emergencies, right? Someone where who needs emergency intervention to offset or deal with an acute problem. But oftentimes, and I can say from cancer perspective, many of my new cancer patients, their first point of entry is through the emergency room as opposed to through their primary care or their community physician. What's the messaging to the community in terms of who really should walk into an emergency room?
Um, that's a very tricky question. I work for the city of New York, and um, the manner that we're told, we see everyone that comes in here, but because unfortunately, most people don't have regular health care. Some of it is for insurance purposes. Most people don't have regular health care, so they use the emergency room. You'd be surprised what people come in the emergency room for. They come in there for flu shots. you know. So we have a separate area within the emergency room that deals with what's called quote unquote urgent care or not emergent, non-emergent issues. So I work in a unique setting where we provide all those services, but traditionally an emergency room is for people who are really having an emergency. But unfortunately, you know, people feel like, whatever's going on with their health is an emergency to them. you know, somebody has a stuffy nose. For some reason, they feel like that's an emergency. And very small percentage of those patients will end up having something that's detrimental. I'm not saying no. However, for the most part, emergency rooms are supposed to be people who are generally will be brought in by an ambulance because they're that sick. But even ambulance services these days, you find that ambulances, anyone can go get in an ambulance and and get a ride to the hospital. I don't know what's the mandate in the field that tells them that there's no criteria for someone not being able to go into an ambulance. And we live in a litigation society where people don't want to be responsible for denying someone the care they need and then being sued for it because they were mistriaged.
Yeah, because the big conundrum there is it's a double-edged sword. So then you get someone who comes in the emergency room to address an issue which would normally take you 2 hours from start to finish, but they're there for 10 hours because you're dealing with all the other
Issues, yeah.
while they're urgent, they're non-emergent.
Right.
So how do you create a program or a system that help mitigate that crisis? Because I tell you, when you talk about urban emergency room, one of the big conversation is the amount of time they spend there.
I agree. I don't know what the answer is. I see everyone that comes to see me,
Right.
and sometimes we get a lot of patients from urgent care centers. They'll see a patient there who has a chest pain, and they automatically send those patients to the emergency room. So, and sometimes a 20-year-old with a chest pain, depending on who's seeing that patient, may be more comfortable sending that patient home. Um, and then somebody else, they get an EKG, they can't even know how to interpret a basic EKG, and they end up sending those patients to the emergency room because nobody's comfortable with chest pain or shortness of breath. So I always tell people this: you're as good or you're as lucky as who you meet when you come into that doctor's office. Not everyone who works in an emergency room should be in an emergency room, and there are different level of what's the word they use, gestalt, as far as knowing what's really wrong with someone. That word gestalt, it's just experience what you've seen enough where it just makes you, I work in emergency medicine, and I always say you have to have, and I'm sure you guys have the same thought. You have to have an angel on your shoulder when you practice sometimes, because there's certain things that you can cue in and you can zoom in on a patient that somebody else may miss. You shake your head sometimes and says, "Wow, if I wasn't here, I wonder what would be the person's care."
Mm-hmm. So true. So true. Dr. Garrison, please.
Hi, Dr. Garrison.
You're still on mute.
Good afternoon.
Good afternoon, Dr. Garrison.
My name is Jordan Garrison, and I'm a general surgeon. I cut my teeth early on as a trauma surgeon. So I have a couple of questions for you to ask, one trauma related and one general related. The first is if you could talk about, and I correct me if I'm wrong, I think you're at a level 1 trauma center, correct?
Yes, I am.
Okay, so the first question is, could you just talk about some of the changes that you've seen in trauma care in the emergency room? When I first started, the caliber of guns were very, very small. So people would come in and we had a lot of, surgery to do. But as time went on, the caliber of the guns changed and people come in dead. And, there's very little we can do because of the caliber of guns. So some changes in the resuscitation have gone on. We used to give a lot of fluids, and now it's a combination of blood and fluid. So if you could talk about that, that's first question. And the second question is, with this fentanyl epidemic, and I'm going to call it an epidemic, what kind of changes have you seen in the emergency room, the ED, with fentanyl going on? So that's two questions. If you wouldn't mind answering those, greatly appreciated.
Okay, first I want to acknowledge Dr. Garrison. He probably doesn't remember me. I was a medical. Yeah, good. Tell me. Good. Tell me. You jumping up.
Oh, yes. I thought that face looked familiar. Okay. You were the one with all the questions all the time.
Just minus the gray hair. Just minus the gray hair. I had the pleasure of doing my surgery rotation at St. Michael's.
Yes.
And I had the problem to be under the tutelage of this great vascular surgeon at the time.
Tell me more. Tell me more.
A long time ago.
Yeah, we're still around.
I think my chief was Darren. I remember Darren's last name.
Oh yeah, Darren. We all know Darren. Okay,
Darren. That's right.
Cardiothoracic surgeon.
That's right. We're going way back. We won't go into that conversation. Speaking of, so trauma has changed a lot in the emergency room. Before, the trauma surgeons, actually, the emergency medicine was traditionally under the service of trauma surgery, under surgery. And some places it is not that many places anymore, but some places it really existed as such. Now emergency medicine, as you know, is a field all to itself, but we work very closely with the trauma department. Some places there's some kind of a adversary type relationship between emergency medicine and the trauma department. But for the most part, when you find a department that works synergistically together, you find the best outcome. And one of the main reasons for that is that one of the biggest advent in trauma, blunt trauma, and even in penetrating trauma is the use of the bedside ultrasound. And I will say the bedside ultrasound has kind of was catapult my career, because I did ultrasound before I actually went to medical school at SUNY Downstate in Brooklyn. I did my bachelor's in ultrasound. So when I arrived on the scene in emergency medicine, I was a hot commodity. And if I was white, I would probably be on billboards everywhere. The amount of doctors that I've trained in ultrasound.
We know that feeling. Okay.
We know what we talk about, but however, I still continue to train doctors, and some of them have gone on to be, famous, and I'm still here, but that's another story. So I've trained a lot of doctors in ultrasound through the emergency room, trauma, as you know, blunt trauma. There's a test called a FAST exam. which allows doctors to quickly ascertain if they have free fluid in the abdomen. Uh, Traditionally, they would do what's called a DPL, which I'm sure you're familiar with, where you actually put basically a syringe in the abdomen, and you try to see if there's any blood in the abdomen, with syringes and stuff like that.
Yeah,
And
in the GYN field, we used to do a coldocentesis. You remember that, Dr. Garrison?
Yes, yes,
yeah,
indeed.
so
It was
basically
painful.
Oh, tell me about it.
you put a catheter in to determine if there's any blood or
Yes, in the pelvis.
in the abdomen or the pelvis.
Yeah.
Now ultrasound with very high sensitivity can tell you if there's free fluid in the abdomen. It can't tell you where that fluid is coming from, but you can, based on your clinical presentation of that patient, you will decide if that patient needs to go to the OR immediately. And you can, in many cases, avoid the CAT scan, especially when the patients are unstable. Ultrasound can be very helpful. As you mentioned before, we get a lot, penetrating traumas is very tricky because I don't think much advances have been made with penetrating trauma. As you said, if somebody gets a gunshot wound, these guns today are so destructive that many of those patients still don't make it to the emergency room. But sometimes some of those patients come to the emergency room, especially stab wounds to the abdomen, stab wounds to the chest. They stand a better chance than gunshot wound, as you know. That hasn't um, changed much, despite the advent of being able to diagnose this quicker. These guns are just so destructive that it really doesn't change the outcome in many cases. Um,
Can I just interrupt and hold your thought? Can you explain for the
Right,
general
what?
public ultrasound and what an ultrasound is?
Ultrasound is a technology that uses sonar waves. Traditionally, people know women who are pregnant, they go in and they get an ultrasound to look at the baby, and the baby is moving. Mommy feels happy. Mommy hears a heartbeat. She feels reassured that everything's okay. And that's traditionally what ultrasound was used for. Um, Ultrasound has evolved more. There's diagnostic ultrasound that's used to break up kidney stones sometimes, but that's a whole different area. We're talking about diagnostic ultrasound that's used to basically see what's going on with the patient on the inside. So it avoids a lot of invasive procedures. What's invasive? Things that make you have to actually cut or go into the body with different instruments. Ultrasound allows you to stay on the outside and you can look to see what's going on the inside. And the main thing that ultrasound helps you to do in a trauma setting or even in an ectopic pregnancy setting is to look for free fluid. Uh, Especially when it comes, let's talk about ectopic pregnancy for a second. We don't necessarily, I teach my residents, we're not here to look for ectopic pregnancy to find where this fetus is. We're here to make sure that there's no free fluid in the abdomen, and if we don't see a normal pregnancy, we assume it's an ectopic pregnancy, and it's the safest way to be. Then we call our GYN specialist to come and help us sort it out. But if we see free fluid, then everyone runs downstairs right away and try to figure out where's that free fluid coming from. Is there a leaky pipe somewhere inside, or is it a ruptured ectopic, or whatever? So, and it's the same thing with trauma. We see free fluid in trauma. We assume that there's something that's bleeding, and we have to have the trauma surgeons come in and actually um, do their thing. I will say that patients on the outside don't understand that if you're having a really true emergency, really especially a trauma, your best bet is to go to a trauma center. Don't go to another hospital just because you feel like they're not going to be busy. You want to get yourself to a trauma center because many times, unless this surgeon is comfortable doing trauma, he doesn't want to put his life on the line for something that he hasn't done in about 15 or 20 years. If he has to, he will, but he'd rather for you to go to a trauma center where they have all the other subspecialties there that you may need to have a vascular surgeon, you may need to have an orthopedic surgeon, or even an ENT doctor. So if you have a real true trauma emergency, your best bet is to go to a trauma center, level 1 trauma center.
Excellent, excellent.
As far as the fentanyl outbreak, Dr.
Oh,
Garrison had mentioned about
yeah.
fentanyl and these drugs. As you know, drug has plagued our communities for many, many years, and nobody really cared that we were dying from heroin overdose and all these different drugs. what has happened in the last 10 or 15 years, other populations who remain nameless have found these drugs in their communities. And drugs don't discriminate. Everyone, everyone in these in all communities, you'll find a subsection of the population that's going to be addicted to drugs. And when certain populations become addicted to drugs now, there's a big push. This war on drug has become a big push to eradicate drugs out of their community, and fentanyl is one such drug. As you know, fentanyl was traditionally used in the hospital, and I don't know, maybe Dr. Garrison could tell us when this drug fentanyl started to go into the communities. I don't know when that happened. Synthetic drugs are something that's manufactured sometime outside of the country, and they find their way here in the United States now. And because certain populations that are non-black are being affected by it, now there's a big push. They're giving out Narcan, which is a drug that helps to reverse the effect of some of these opioids or some of these drugs like fentanyl. But the problem is many of these drugs are mixed with other things besides fentanyl, and they're having a hard time trying to control and save lives. We see a lot of addiction in the Bronx. We see a lot of overdoses in the Bronx, but a lot of them don't actually make it to the hospital. So,
Yeah, so if I might just say something, it's interesting that I remember even as a young medical student, as a medical resident, Narcan was one of your biggest tool in your toolbox when you're in the emergency room, right? And I was camping out in the rural areas of a community which I will not name, and I went into the pharmacy and I saw the big sign, Narcan available without
yep,
prescription.
that's
So
right.
in terms of policy changes, just the way there are medications that used to be prescriptions only that are now over the counter, you can get a medication that can seemingly reverse an overdose out in the community when your average person can walk in and say, listen, I need some Narcan because my friend, my relative, or whoever seemed to be suffering from an overdose. So that was a little bit of a surprise to me when I saw that initially. Um, and then the other thing with ultrasound, it's interesting how it's come a long way in a diagnostic perspective in the ER, but from a therapeutic perspective, I remember Dr. Garrison as a general and trauma surgeon and vascular surgeon, we used to do vascular access through our knowledge of anatomy, right? So now
Right.
we don't have to do that anymore, go into the middle third of the clavicle or any question with respect to that. To gain
Right.
access to get an vascular access, you take the ultrasound and you look and you find the vessel, and you easily access the vessel. And the advantage there is you don't have to worry about the side effects of doing it, causing injury by doing it blindly. You're more targeted. So it's interesting how the technology has influenced what goes on in the emergency room.
Can I just add a couple of things to everything that's being said? Um, two things that I keep in my car now is I keep an EpiPen in my car and I keep a nasal spray of Narcan. I was at a basketball game locally at Seton Hall, and one of the students just fell out in the hallway, and I think it was a combination of beer and whatever else he did at the frat party. But the EMTs who were on site, the first thing they did was sprayed his nose with Narcan, and guess what? He woke up.
Yeah.
They're putting this fentanyl in everything. I even hear that they're mixing it in marijuana.
Right.
You know, drug dealers want to make money, and fentanyl is cheap and it's easy. People that use drugs want to get high, and the better the drug, the more demand it is. So this is one of the things we're plaguing. And if you don't mind, if I just take a couple of seconds, and I don't want to steal your thunder, Dr. Dixon, but I do remember your ultrasound teachings, which helped me. Presently, I'm doing venous surgery, and we use ultrasound all day long as a diagnostic tool. And the thing about the ultrasound, just for the layperson, what ultrasound does, it sends sound waves into the body or whatever area of the body you're working on. And depending on how thick the tissue is, you'll get a reflection of those sound waves. Sort of like, when you're watching movies and they're looking for the submarine at the bottom of the sea, the sonar sends a sound wave and it bounces back. Metal has the highest bounce back. Air and water has the least bounce back. So when we look at the images on a screen, anything that's metal is going to appear white, the highest density. Anything that's water or air is going to appear black. And by determination of looking at those different densities, we're able to see certain structures. And therefore, as Dr. Anderson was saying, you know, I don't think there's a resident now who knows how to put in an IV without use of ultrasound, whereas we had to rely on anatomical conditions in order to put in certain types of IVs. So that's the advent that I see ultrasound doing. And it's, you know, my daughter was in the emergency room and they couldn't find an IV. And I called, she was in Florida. I called and said, listen, get an ultrasound technician down there. And they came and they were able to put the IV in jickery split. So it is a very helpful diagnostic tool and is greatly appreciated in our armamentarium in treating emergency situations.
Excellent, excellent. Dr. Court, please, you're next.
Thank you. I remember when trauma started, I was at University Hospital, and when that red phone rang sometime about 1981, they had the medical team ready and the surgical team ready. Then they started with trauma team 1 and trauma team 2. But in reference to something that Dr. Dixon said, can you tell us what does FAST mean? If I see a patient, what does F mean?
Focused. Focused assessment of sonography in trauma.
Does every facility usually carry this out? Like say at Noor Beth Israel, do we have that?
It depends who's on.
Yes.
You know, like I said to you before, you know, medicine, as you guys know it, a patient life depends on who's on that night. And we know better than that's why if a loved one's in the hospital, we're there because we know it depends who's on. I mean, some doctors, you know, are not comfortable using the ultrasound. Some doctors cannot use the ultrasound. Um, but I'll tell you, we've used the ultrasound. I went to Jamaica. I went to Jamaica and I was doing a health fair in Jamaica in the hills of Trelawney. And one of my residents that I brought down with me, we had a handheld ultrasound. There's a new handheld ultrasound called a Butterfly now. And it's not the best device in the world, but it works very well in the field. And it's for poor countries, they can be able to make these diagnoses now. And my resident put the probe on a woman who was lightheaded and dizzy, and we saw a large pericardial effusion on this patient. And we were able to transport her to get that pericardocentesis and have that drained out and analyzed. And she had like 500 cc's of blood around her heart, or fluid. I'm not even sure what the fluid was, but I'm assuming it could have been some, you know, sanguineous. I'm not sure what was in that fluid, but we were able to get her to the care that she needed because of the ultrasound. If we didn't have the ultrasound, we wouldn't have. There's no way we'd have known that this was going on this woman, in the field like that. So,
Can I
ultrasound.
I have one. I
Can
have
I
one more
just add,
question.
Dr. Court,
Yes.
can I just add some? We're talking about a fast scan, and basically it's an ultrasound. You know, for our audience, the belly or even the lungs are cavities, and there should not be any free fluid in that cavity. The organs should contain those fluids. So what we're looking for when there's trauma to the belly or to the lung, we get leakage of fluid, whether it's intestinal fluid or whether it's blood into that cavity. That's an indication that some type of intervention needs to be needed. Therefore, when we do a fast scan, again, as Dr. Dixon said, it can't tell us where that fluid came from, but it can tell us that there's fluid in the cavity that shouldn't be there. So therefore, some type of surgical intervention should be entertained. What that intervention may be and the algorithms for taking care of the patients with that fluid varies, but there needs to be some type of intervention. What I can say at Beth Israel is, although I don't know about the emergency room physicians and their comfortability with this technique is, but I do know there are surgical residents there. And from the time they're interns, they rotate through the trauma services at least 2 months a year. And they are very familiar with these techniques. and adept at being able to read them. That has been an addition to the surgical board exam, that you have to be able to read these ultrasounds and well as make a diagnostic decisions based upon it.
And that's a good point, Dr. Garrison, because I think the policy changes that has happened through medicine is what is causing this push now for everyone. You can't be a department, especially you can't be at a trauma center unless everyone knows how to do a fast. It's not acceptable anymore to just say, I could just use my Gestalt. They want to see you be proficient in the ultrasound, especially to do, as you said, the fast exam. That's something that's very important.
I do believe at
Good
Beth
night.
Israel
Oh.
that technique is employed quite often, because in many of our cases, whether it's at the M&M's Monday morning or in the in some of the RCAs, the result of the fast is usually presented as part of the presentation.
Right.
Yeah.
All
Can I
right.
ask a
Dr.
question of
Appleby.
my good friend, Trevor Dixon, who I've been privileged to work together with, even on one of the missions that he held in Jamaica. Good afternoon. I also apologize because I came on late and have to leave very shortly. I have to attend a wake for one of our co-workers. In any case, I wanted to ask, yes, ask Dr. Dixon.
Yeah.
In my field specifically, interventional cardiology, it is often imperative that we quickly make the diagnosis and act expeditiously, because as we all know, in patients who are losing muscle through a heart attack, time is muscle. And the longer we wait to go in and intervene and correct the problem in patients who are having an acute heart attack, then the more damage occurs to the muscle. So let me ask you, how important is the ultrasound in helping us to quickly make the diagnosis when a patient is having a heart attack?
Good.
Dr. Dixon, you're on mute. You're on mute.
Yes, yeah, you can hear me now? Yes.
Yeah, we can hear
Yes.
you.
That's an excellent point. It's so important. Being able to do an EKG is also a very important tool. It's a primary tool we still use to determine if somebody's having a heart attack, what's called a myocardial infarction. We still use the EKG as our primary tool. However, our Gestalt is also important. As you know, Dr. Athley and I have both worked on patients in the emergency room who have very subtle changes to their EKG sometimes. But now with the advent of ultrasound, I personally use the ultrasound to see if there's any what's called wall motion abnormalities. Very few emergency physicians are doing that, but I'm one who is, I came from an ultrasound background, as I said before, with my bachelor's in ultrasound, and I worked at Kings County doing a lot of echocardiogram. Dr. Court and I have been to Jamaica doing some echoes also. But I do know the importance of ultrasound, and that's going to be an emerging field as far as using ultrasound in cardiology. But for primarily right now, they use the ultrasound just to see if there's any free fluid in the in around the heart. They're not really looking at wall motion abnormalities. Although some doctors will be able to assist the cardiology fellow who comes down to the ER to kind of see, is this really an MI or is this just an abnormal rhythm?
Okay, just so that we can explain to our audience what we mean by wall motion abnormalities. When the heart contracts, all of the portions of the muscle, and we talk about the most important pumping chamber, the left ventricle, the portions of these are supposed to contract synchronously, properly squeeze the blood out to where it's needed in the rest of the body. What a heart attack does is focally attack specific areas of the heart. So the whole heart may not be affected by a heart attack, but the heart attack may cause death and damage to specific, limited, local areas. So when we do the echocardiogram, when Trevor does the echocardiogram for us, for example, he can show us if the heart is contracting equally in all areas, all the walls, or if there's specific walls which are not moving as well as the others, and can give us the impression that those areas may be areas of heart attack or pending heart attack. So yes, I agree, it's very important. The wall motion is certainly one of the things that we would look at in patients who come to the emergency room, the chest pain, suspected acute heart attack. Thank you.
All right, excellent. Dr. Court, I see you still have your
Yes,
hand up. Was there a second
correct.
question?
Yes. My question
Please
to
excuse
Dr.
me, I have to run
Dixon.
back in. Sorry.
All righty, Dr. Thank you, Dr. Trevor Atherley.
Thanks.
So Dr. Dixon, patient comes to the emergency department, probably overdosed in something. How can you differentiate between whether this would be heroin or cocaine or fentanyl?
You're on mute again, Trevor. You're on mute, Trevor. You're on mute. There you go.
Yeah, well, oftentimes it's we don't focus so much on what drug has caused this patient to be unresponsive. We don't have much tools in the emergency room to differentiate different drugs. For instance, we're fortunate that the treatment for fentanyl and the treatment for heroin and most of these opioids is hitting the receptors. It's been able to block the receptors that these drugs are attaching themselves to. And Narcan is one of those drugs that is able to do that. So we're fortunate in the sense that Narcan is a universal drug that can affect many of these overdoses. And we're talking about opioid overdoses. On the other hand, we have cocaine, which acts in a different manner. It hit different receptors. So we use benzodiazepines, which is.
There you go. All
Hello?
right. Thank you. Thank you. All right, Doc. We appreciate it. When do you want to come in?
Yeah, so we use other drugs depending on how the patient presents as far as a drug overdose. You can have a drug overdose from cocaine, which would present differently from a drug overdose from opioids or heroin or those class of drugs. So we just we don't look for the cause of drugs. What particular drug, we don't look for the particular drug because there's so many drugs out there, and as you know, there's mixed use. People use marijuana with fentanyl. People use marijuana with cocaine. So we basically looked at the effects of the drugs. That's what we basically treat the effects of the drug.
Excellent. Excellent. All righty. Dr. Anderson, go ahead. Please, you got your hand up.
Yes, Dr. Dixon. So most of us, our perception of an emergency encounter is usually a physical issue, something that can be managed surgically or medically. However, in a time, especially post-COVID, where we see a lot of mental health issues, can you just talk a little bit about the structure of the emergency room and how they are implementing intervention for mental health crises, which oftentimes are more emergent than we think it is?
Okay. Can you hear me?
Yes.
Yes, we can.
Good. That's a very good question. Like I said, I'm fortunate. I work in a very large level 1 trauma center, so we have access to all the mental health care that a patient would need. However, smaller communities, what they do, they can triage patients, and when they find that patients are, for instance, the biggest concerns for mental and psychiatric emergencies is the question is this patient suicidal or homicidal? Which basically mean, does this patient want to hurt him or herself, or does the patient want to hurt someone else or want to kill someone else? And those are the big main areas. You'll find that there are more sympathetic emergency rooms who will admit patients who are just depressed, even though they don't want to hurt themselves. But for the most part, a lot of these patients who are suicidal or homicidal will be transported out to a facility that can best care for that type of patient. I know Beth Israel has a very complex psychiatric department they can deal with at University Hospital. But when you go to these smaller communities, these suburban emergency rooms, you might not find a comprehensive psychiatric care. You might not find it available at those particular hospitals, and those patients can be transported out to facilities that can deal with it. But our biggest concern is patients who are suicidal and homicidal. And some patients will tell you that they're suicidal and homicidal, and you may feel that they're not, but it's not for us to judge. I don't have enough psychiatric training to put somebody's life, me personally, on the line to say, I don't think this guy is serious. He's just, trying to get attention or whatever. So I think anyone who has a psychiatric concern, anyone who says that they want to hurt themselves, we as physicians and also as family members should try to get them the expert care that they need. Because sometimes you know these psychiatrists and psychologists can tease out information that we wouldn't normally be able to get, and they don't. We don't. Sometimes you just take one person to be able to reach that patient and make the difference in that patient's life.
Excellent. Dr. Garrison, I see that you're driving now. You are on mute again.
Okay, I'm here. Okay, I just want to switch over to COVID for a second, and not necessarily about COVID, but the changes that had been made. For instance, like they say in wartime, a lot of innovation comes out of war. With COVID, there have been changes in the algorithm of treatment. For instance, everybody's familiar with appendicitis. And the adage was, you know, you never let the sun rise or set on a appendix. But now with COVID, people could not get into the operating room. They were just closed down and all the precautions. So the algorithm switched to antibiotic treatment for appendicitis. And very few people have to go to the operating room now for appendicitis. What other things have you seen in the emergency department that have changed because of COVID protocols?
Let me make sure that he heard you because I know that he was adjusting.
Yeah, we were seeing we were seeing changes. We were seeing changes initially with COVID. When COVID was in its high demand, we were still. I'm at a level 1 trauma center. We had a lot of volume from COVID, but we were still able to treat appendicitis in the emergency room. I can imagine a lot of those local smaller hospitals weren't prepared how to deal with that, but we were fortunate that all of our services were, although the services were not available. Jacoby is unique in the sense that all the trauma surgeons are very active general surgeons, so they were still able to function with COVID restrictions as far as appendicitis and stuff like that. So all the trauma surgeons that are at my facilities, they're pretty much the ones that run the general surgery department. So we didn't see much difference there as somewhere else. Like maybe New York Beth Israel may have had a different experience because, you know, they're not all, you know, trauma trained, and so they weren't always in the hospital because they had to do what we call elective cases, which you could probably speak more about than I would. So I didn't see that much effect where I was in the Bronx here.
Alrighty.
But I will say, as far as COVID, I guess we could talk forever about COVID, but what we noticed in COVID, that COVID carried a lot of comorbidities. Like COVID would cause pulmonary embolism, you know, COVID would cause heart attacks, you know, COVID was causing strokes. So that made it even more complicated when we had patients that came in the emergency room to figure out it wasn't just COVID, it was COVID and something else, you know?
Right. I know that from a lung standpoint, and I definitely had seen post-COVID patients, and they call it long COVID now, that have had pulmonary emboli. And the residual from that is continued shortness of breath, especially on exertion. There is some, I should say, bronchospasm, like the airways spasming, and you hear some wheezing. But on exertion, that shortness of breath lasts quite a long time. It seems like over time it does improve with basic pulmonary treatment, it seems. But yeah, long COVID, as far as the respiratory, seems to be something that we're dealing with at this particular time. And I just want to ask a question. You know, I know that the emergency room, when you talked about the function of the emergency room, like, and things like that. But what about certain emergencies? I know from a respiratory standpoint, when someone comes in and they truly cannot breathe, what exactly is the protocol, or what happens to that patient? How do you handle it when they walk in the door, or they stroll in the door, or they're rolled in the door? How do you handle it from an emergency standpoint.
The first thing you gotta do is stay calm.
Mm, yes.
And that can be a real issue sometimes for folks, even professionals. But I will say that the treatment of the patient that is short of breath has changed dramatically over the last maybe 20 years or so, as you know, Dr. Bay. When the patient say I can't breathe, you need to take that very seriously. They can't breathe. If a patient perceives that they can't breathe, it could be for many reasons. And there's a feeling that there's a term we use in medicine, in emergency medicine, called that feeling of doom, where that patient tells you, you know what, I feel like I'm going to die. Okay. Now, in emergency medicine, I personally, I take that very seriously. Okay. If a patient tells you they feel that they're going to die, anxiety is the last thing I look for a cause for that. I have to have explored every avenue before I tell you that patient is anxious or just anxiety. Okay. So I see a patient being diagnosed with anxiety. I'm like, if I feel like I was going to die, I think I'd be anxious too. So,
Mhm.
and as you know, people who are having pulmonary embolism, that's one term that they use. I feel like I'm going to die. If somebody feel like they're having a heart attack, they always tell you that they feel like they're going to die. And I've had instances where people tell you, you know what, I feel like I'm going to die, and they actually do die in less than 5-10 minutes from when they told you that. So, I personally take that very seriously when somebody tells me, I feel like I feel like I'm going to die. And back to the shortness of breath, though. A patient comes in, say I'm short of breath. If you're lucky, you can hear wheezing,
Mhm.
and that makes you, those patients die too. Asthmatics die.
Mhm. Sure.
From asthma attacks, even after arriving to the emergency room, if they don't receive the proper care. Right? That's number one. Number two, you have patients who have congestive heart failure, and those patients also feel like they're going to die and they can't breathe, and they also need to get the proper treatment. If you can't properly treat them, also they can possibly die too. Right? And then you have patients who are having a heart attack who are saying, I can't breathe, or I feel like there's an elephant sitting on my chest and I can't breathe. And those patients also need to have a specific treatment. So the physician have to be able to identify, oh, what are we dealing with? Or are we dealing with a dissection? You
Mhm.
know, all these patients can come in and say, I can't breathe, or I'm in distress, or I feel like I'm going to die. So basically you put these patients on a monitor if you're lucky, and sometimes you can't put them on a monitor. You have to just kind of support their breathing, and especially in the case of I can't breathe. And if you see that the patient is diaphoretic, patient looks diaphoretic, it's not a good thing, because you're trying to figure out, are they having a heart attack, or are they having a stroke, are they having a dissection, are they having an asthma attack, or are they having congestive heart failure. So you have to be able to quickly be able to, number one, ABCs, airway, breathing, and circulation. You have to be able to support their breathing. And sometimes you can actually, they can turn blue and you can lose them right there in front of you, as you know. And you have to basically be able to intubate them quickly if that's what they need to protect their airway, until you figure out what else is going on with them.
Right. Intubation is putting the tube down the throat. What you said ABC? Can you explain that? Because I don't think the public, yeah, I understand it, but just break it down just a little bit more so the public can understand, because this is important.
Sure. ABCs basically means airway, which means, can the patient take in oxygen and exchange oxygen for carbon dioxide coming from the lungs. So ventilating is a patient being able to breathe. Breathe doesn't just mean taking in oxygen. It means also being able to get rid of carbon dioxide. So can the patient breathe or ventilate? If the patient cannot breathe or ventilate, which means the patient either has unable to take a breath, or there's an obstruction why the patient cannot take a breath, you have to do what's called support their breathing by putting a tube in that goes through their mouth and goes down and kind of help the lungs to take in oxygen and get rid of carbon dioxide. And that tube, it looks like almost like a plastic tube. It's almost like a huge straw that goes all the way down, and it actually helps to breathe for the patient until we can figure out why this patient is not breathing. Obviously, if the patient is not breathing, the worst case scenario is that the heart has stopped. Okay, and if the heart is stopped, then in addition to have the tube in to help the patient breathe, we have to be able to get the heart to pump. And sometimes we have to artificially pump the heart by doing CPR, by pressing on the chest in a timely manner to keep the blood moving throughout the body. And that's the key, to keep the blood moving throughout the body. And one of the main organs that you don't want to not have blood is the brain. So that's why CPR is so important, because you want to be able to perfuse the brain, which means give the brain oxygen until you can figure out how to get the heart going again. So there's that, so when a patient that's the most complicated part of I can't breathe. Fortunately, most patients don't come in like that. Most patients come in with what's called wheezing, and if they're having an asthma attack. And asthma is very pervasive in the urban areas for many reasons. There are many triggers for asthma. That's a whole nother topic that Dr. Bay, I'm sure, has covered. But in emergency room, when somebody comes in with wheezing and usually they have a history of asthma, you treat them one way. If they don't have a history of asthma and they come in with wheezing, you have to worry about what's called an allergic reaction. As Dr. Garrison has mentioned before, he spoke about having an EpiPen. So patients who come in and are wheezing because they can't breathe because of an allergic reaction, an EpiPen becomes very important because it gives them a drug called epinephrine, which is good for causing opening up the airway, so to speak, and helping them to breathe. And it also helps to increase the blood pressure to bring blood back to the heart and to the lungs and to the brain. So EpiPen is important in that sense. You see, sometimes people have an allergic reaction, their face gets swollen, and sometimes it could be swollen to the point the patient's face looks distorted. You can't recognize what the person looks like. Those patients, from an allergic reaction perspective, would need to have the EpiPen immediately. And that's why Dr. Garrison said he walks with the EpiPen, because he knows that without that, he's helpless in helping somebody who needs help. And if he has that, he's a hero, so,
Yeah. With respect,
that's one aspect of I can't breathe. That's allergic reaction or asthma, right? And you can give, bronchodilators to help those patients. You can give steroids to help those patients also. That's another area. And I can't breathe can also mean you have congestive heart failure. And the management of congestive heart failure, I don't know if Dr. Atherley is still on the phone, on the call, but congestive heart failure management has changed drastically over the past 20 years with the advent of what Dr. Bay has talked about, the BiPAP machine. Now, the BiPAP machine is a machine that helps to breathe for the patient. The patient basically has a mask over his mouth and nose, and that actually prevents them from having a tube being placed down their throat. And that is less invasive than having a tube placed down your throat, but it's a mask that goes on your face, and it actually gives you oxygen and helps you to breathe until it reduces the stress of you being able to breathe on your own. Okay, but those patients should have some level of mentation. They should be able to somewhat cooperate with the BiPAP machine. And that's a bridge to get the medications going. Like if somebody's having congestive heart failure, it would mean that they would need to get drugs to lower if the blood pressure is extremely high. Usually those patients comes in blood pressure 212 over 120 or in that range, or what it could be 186 over 100. But usually patients who come in with CHF problem, congestive heart failure problem, their blood pressure is very high. It's usually after Thanksgiving when they had all that turkey and all that other stuff with the salt, and they have that salt overload, and now they have to get rid of all that extra fluid that the salt has drawn into their body. And lowering the blood pressure is key, but until you can lower that blood pressure with usually the same nitroglycerin pills or whatever you have, the IV nitroglycerin, you can use the BiPAP machine, as I mentioned before, and that can buy you some time until you can get those medications going. Because usually, they run through the emergency room. You have no time to really prepare. So it gives you a little bit of time until you can get those medications going. And that has prevented a lot of intubation. Before, congestive heart failure patients would be intubated. We have the tube placed in their mouth and placed on a ventilator until we can stabilize them to that point. Nowadays, the BiPAP machine buys you a lot of time, and maybe about 10% or 5% of those patients end up being intubated anyway, but it still saves a lot of hospital resources by not intubating these patients. So that's as far.
Since you brought up BiPAP, let me explain what BiPAP is. BiPAP, there are two basic masks that we use. Number one is CPAP, and CPAP basically allows you to take what it does, and the reason it helps with obstructive sleep apnea is that it gives you a positive pressure in the back of your throat and allows it prevents your soft palates from falling over in the back of your throat, such that it helps with you breathing and not cutting off your air during sleeping. And it gives a positive pressure in the back. A BiPAP, the reason they say bi means both ways. It allows for you to very easily take in oxygen because it holds your airway open under inspiration when you're taking in a breath, but also it relieves that pressure when you're trying to exhale as well, when you're trying to get rid of that waste that we have, the CO2 that we need to exhale off. So it helps in both ways. It helps with inspiration or breathing in, and it helps with expiration, breathing out. And it allows you to get oxygen in and get rid of that CO2 in an easier way, such that, as Dr. Dixon said, it helps prevent us from putting that tube, that intubation tube down and putting you on the machine, which is called the ventilator. Thank you. Dr. Dixon, you want to say anything else? I know Dr. Garrison has his hand up.
No, I think you covered it so nicely, Dr. Bay. Yes, Dr. Garrison.
Yeah, um, the trauma standpoint, A is airway, of course, which you said, and must make sure that there is a free exchange of air. And that's where people will turn the head to the side, stick the finger in the mouth, and kind of sweep out the airway. And anybody at home, if anybody falls or they seem unconscious or they're having a seizure, that's what you want to do. You want to lay them down, you want to turn the head to the side, stick the finger in the mouth, and make sure you clear out any hot dogs or potato salad or whatever it may be that that person has choked on if you're at the family picnic. And where the maneuver.
Yeah, I think we lost Dr. Garrison. He's in a low reception area.
But that's okay. That's a good point Dr. Garrison mentioned. I can add to Dr. what Dr. Garrison said. Like,
Okay.
as you said, if you're on a family picnic or wherever you are, and you see somebody say, I can't breathe, I can't breathe. Once you want to do, as Dr. Garrison said, you want to just sweep the airway. You can put your hand in that mouth, make sure there's nothing obstructing the breathing. And there's also another thing called a Heimlich maneuver, which means you're trying whatever you can to stop the obstruction. And sometimes they teach you how to do with these abdominal thrusts, so you see those people standing behind the patient and kind of pulling their stomach upwards to try and relieve the obstruction. And that's in a desperate situation. And many times that can be very effective in helping that person to expel that whatever is obstructing in most cases.
Excellent. Now, talk Dr. Garrison, I know you're talking, but
You're on mute.
Still muted. You're still muted.
Okay, yeah, just the funny thing, you can also do the Heimlich maneuver on yourself if you're ever out alone by falling over the edge of a chair or a stationary object. Now, when we go, so once you clear the airway, there's an equal exchange, then it's breathing. You must make sure the patient is able to breathe. If not, then you must create a way for them to breathe. And that's where we're talking about the techniques of BiPAP, CPAP, and intubation, or putting the tube down. So that has been covered. Don't want to go into detail about that. The third thing is the C. C stands for circulation. When a patient comes in distress, you must be able to establish a way for them to continue their circulation so that you either put fluids or medications in. And that would either be intravenous, there's central lines. In children, sometimes you could put an IV in the leg, near the bone of the leg or in the bone of the leg to get the fluids in. Then there's a further thing called the D and the E. And the D is for diagnostics. Once you've stabilized a patient with those things, then that's when you order x-rays. You can order CAT scans. You can do the fast scan. et cetera, et cetera. You can call OBGY. Dr. Anderson, do you still do transvaginal ultrasounds, or do you rely on fast scans for developing blood in the pelvis for ectopics?
Yeah, I mean, it depends on the circumstance. The fast is helpful if you're worried about a rupture or a blood in the abdomen. But if you worry about other potentially surgical emergencies, like a torsion, which is when a gonad or an ovary, whether it's in a male or a female, ultrasound is also very helpful. Especially, I know Dr. Dixon's experience. He not just only look at what could be fluid in a space or in a cavity, but he also has the ability to look at blood flow into certain organs. So in an emergency where someone comes in with an acute pelvic pain, whether male or female, he can actually use the ultrasound to look at blood flow to a testicle or blood flow to an ovary and call him the urologist or the OBGYN emergent and say, listen, we have a young person here with a torsion that needs to go to the operating room emergently in order to save this organ.
Excellent.
I just
Okay.
want to add to what Dr. Garrison was saying before. He brought up a very important point with circulation. I just want to add, sometimes we think of circulation as just IV access and giving blood products and not whether products in need. But part of circulation also includes stopping the bleed. If you see someone is bleeding, part of that C is to be able to apply pressure and stop that and tamponade that area that's bleeding. In particular, if somebody has got a cut in the arm and they're bleeding from the arm because it hit an artery, you have sometimes you have to put on a tourniquet to stop the bleed, because people can lose a lot of blood from an artery in a short space of time. And if you're able to put on a tourniquet, and if you can just see that the arm is bleeding, you put a tourniquet above the area where there's obvious bleeding, you can actually save that person's life by not having them lose too much blood that the vital organs will need. So part of circulation for in any emergency is trying to stop the bleed. Obviously, there's some situation, as Dr. Garrison mentioned, penetrating trauma. You're not going to be able to stop that bleed unless you bring that patient to a hospital, particularly try to get to a trauma center. If not, you can try to go to the closest hospital in that situation and try and have a surgeon go on the inside to figure out where is that person bleeding from. How do I stop that bleed? So it's all about stopping the bleed.
All right.
Dr. Dixon,
Dr.
Omar, I have to say this. I really do. The dangers of tourniquets, please.
Okay. All right.
No, I understand, but as you know, Dr. Garrison, there's some instances.
I would strongly advocate not for the general public.
No, it's
use tourniquets.
I agree.
Yeah, because with tourniquets, you cannot achieve a high enough pressure to stop arterial bleeding. What you do with a tourniquet is you stop the venous return, and that is a bad thing. The most simple and easiest way to stop a bleed is simply put your finger over top of it, or hold gauze over it.
Yeah.
I would not advocate for the public to put tourniquets on, because they will make situations worse. I know what you mean by tourniquets.
Duly noted.
I know what you mean by it, but not for the public. Okay.
Right. Duly noted, sir. I stand corrected.
All right, let me do this. Dr. Anderson, I see you have your hand up. Don't. I haven't forgotten you. But this conversation has been so engaging. We didn't do our second half announcement, so let's go through those one real quick, because that's important. What I'd like to do is each doctor introduce themselves again real quickly, and we will follow my little list here and get it back going in a minute. Dr. Anderson, you first.
Yes, I'm Patrick Anderson. I'm a gynecologic oncologist. My primary role is to take care of cancers of the reproductive system in women.
All right, Dr. Dixon, please.
And my name is Trevor Dixon. I have the privilege of working with everyone on this panel at some point in my career. Some of them have trained me. I do emergency medicine at my Jacobi Medical Center in the Bronx, New York.
All righty, Dr. Court, please.
Dr. James Court, internal medicine, located in East Orange, New Jersey.
All righty, Dr. Garrison.
Really, my name is not Garrison. I'm Barack Obama. Actually, this has been a really, really good discussion. It's very lively. and I thank Dr. Dixon. But I'm Jordan Garrison. I am a general surgeon. I am bariatric trained as well as vascular boarded, and my practice in Hackensack, New Jersey. My career path now is diseases of veins with
Right.
ultrasonography. Dr. Dixon, thank you.
All righty. And Dr. Garrison, I want to put the plug on you. You know, we're going
I'm done.
to him.
I'm done. I got no more talk.
No, not the plug, but that type of plug. I mean, the plug meaning that next month we're going to try to bring him in as the person that's going to give us some knowledge from his perspective.
Can,
So
can I just
I'm going to
mention?
nail him down. I'm going to nail him down. He's been trying to.
What are you nailing me down on?
You're going to be the man. You're going to be the man next month.
Can I just
Oh.
interject for a second, Dr.
Yes.
Garrison? This month, as you know, is Women's Month, and I just want to congratulate you and having one of the finest emergency medicine physician who was actually my mentor. She was she carried me through emergency medicine, Dr. Carmen Warren. You have a fine
Oh,
addition.
Yes.
yes, Dr. Warren works with me now at the
That's right.
Metro Vein Center. She has
That's
an
right.
office in Wayne, New Jersey.
You're
She's
blessed.
awesome.
You're blessed. She's been my mentor for many years, so she's a fine addition and to the family, and I'm happy that you have her.
Oh, excellent,
thank
excellent.
you.
Yeah, we all appreciate Karma. Dr. Warren
Happy Women's Month.
He's excellent. He's excellent.
Yeah.
Excellent. Now, I'm Dr. Omar Bey, pulmonary critical care, subspecialty in nutrition. Yes, I was going to say something about New Jersey Medical Association. Dr. Warren, she's very, very active as far as that's concerned. She's on the board with us there, and we're actually have something coming up on the 24th of April, and we are giving a gala, and that gala is to honor and highlight our how should I say, high school students, medical students, residents, as well as fellows. And we give scholarships, and it's just a wonderful affair. So just to let you know that New Jersey Medical Association, the Black Medical Association for the state we're on it as far as trying to increase the amount of Black doctors that are coming out.
And I'll be happy to announce that I will be at that function.
Excellent. Thank you. Thank you. We're rocking and rolling. Dr. Patrick Anderson, you are up, brother. I see you have your hand up.
Yeah, so for Dr. Dixon, in terms of organization and personnel, how do we separate emergencies? We often think of it as primarily adults, but there's also pediatric emergencies. Can you talk about some of the common pediatric emergencies, some of the things that we need to be aware of in children that warrants them coming into the emergency rooms?
Yeah, there's quite a few. Most notably is asthma exacerbation or asthma attacks. Okay, children, especially in urban areas, they seem to suffer a lot more from the ills of asthma. Some of it is hereditary, and some of it is environmental. Dr. Bay could probably speak more about that. So that's one of the emergencies that I when I did pediatric emergency, I treated a lot of patients with asthma, and it's even worse when there is flu season. When you have asthma mixed in with the flu, asthma mixed in with seasonal allergies. Next month, the next 2 months, you're going to have a lot of cases of asthma and asthma exacerbation. And unfortunately, because of not timely being identified these problems, some of these patients actually die unnecessarily. Their pump is not working. Their pump is ineffective. They need steroids. So all those parents out there who are listening, if you have a family member, a child who may not be able to tell you they have asthma, some asthma prevents with just frequent coughing, just coughing a lot, and that's a sign of an asthma exacerbation. So that's one of the common things that come into the emergency room. Obviously, you get runny nose and colds, and sometimes patients actually, young population comes in a lot of headaches sometimes. We see a lot of headaches, and not every headache needs a CAT scan, okay? But some do. So you have to be able to know the signs of a headache. Is this a new headache? Has this patient never complained about a headache before? Okay. Does the patient need glasses? You know, some patients who have strain their eyes, it can to the point where they can have headaches. So the physician has to be astute to what's going on with the family dynamics, and sometimes stress. Teenagers, and they can present with stress with a lot of biological complaints that unless you spend enough time and you can identify with that patient. Emergency medicine oftentimes has to be able to take the time to identify with that patient. If you can make that connection, you can save yourself a lot of money. So sometimes you get mom or dad out the room. Sometimes you can save yourself a lot of money. Sometimes by being able to figure out what is this patient asking for, especially the pediatric population. Another thing too also is ectopic pregnancies. I mean, that's some of the emergencies you see in the younger population when these children are having sex, unprotected sex, and they get these infections, and not just gonorrhea, chlamydia, but the ill effects of gonorrhea, chlamydia, which is sometimes ectopic pregnancies that egg not being able to travel down the fallopian tube, and it results in ectopic pregnancies. And these patients come in young. And so when you ask them, are you having sex? If you ask them if they're having sex in front of the mother and father, they'll tell you no. So, me personally, every woman of childbearing age, from as far as 11, 12 years old, all the way up, I do a urine pregnancy test to see what's going on, in addition to whatever else I'm doing. And if they tell you they're having, if a woman comes in and tells me she's having sex and she might be pregnant, sometimes, when we first started this whole ultrasound journey, we would wait for the urine pregnancy test to come back before we get the ultrasound probe. The way how ultrasound has evolved now is that we can do a fast exam on a patient, whether she's pregnant or not, just to see, does she have free fluid in her belly? So waiting for the urine, sometimes you may wait forever. So if we can put the ultrasound probe down, and before, this is all brand new stuff. Most places are not even doing that. But a woman of childbearing age coming with abdominal pain, we're putting that probe down to see if we see free fluid for and foremost, because that gives you buy you enough time to wait for the urine pregnancy, to wait for all these other things. Because as Dr. Anderson mentioned before about torsions, and we know that the cysts that are more likely to torse are the ones that are 5 centimeters and larger, somewhere around. This is not a gospel, but 4 or 5 centimeter cysts are more likely to torse and untorse and cause torsions. So if we can put an ultrasound probe down and we see a large cyst, I'm not waiting for anything. I called on my OBGYN colleague and said, listen, if she's in severe pain, I see a cyst that's 5 or 6 centimeters, and they'll come down and see it. They're not going to argue with me. But like I said, not everyone is that comfortable using the ultrasound. And that's why I say, depending on where you go and who's working that particular night or day, you can be, time is of essence. You can be ahead of the curveball, you can be behind. And that's just how it is. There's a few emergencies. Of course, abdominal pain is very common in the emergency room with children having abdominal pain, which makes it very uneasy for a lot of physicians, because most of them are constipation. But guess what? Most of them are also appendicitis. And you don't want to be sitting there thinking the patient have a constipation and it's actually appendicitis. Sometimes ultrasound can help you, but for the most part, you're still going to need either a surgeon who has that years of experience, who could just press on the belly and say, you know what, I'm taking her to the OR, him or her to the OR anyway. I'm not comfortable with this. It's the right lower quadrant. Let's not wait on any CAT scan and all these other invasive tests. Let me just take it, if it's not the appendix, I'll just take it out, and then we don't have to worry about that anymore. So the physician gestalt is what's going to be key in all these cases. So know where you're going for your care, and know who's taking care of your loved ones. And those are just a few of the emergencies that they see. And of course, there's always overdose, and a lot of these young kids coming with suicidal ideations or homicidal ideations. So mental issues are also something that's very common in the emergency room. Unfortunately, a lot of our communities, the stress that the parents feel, sometimes the children end up feeling the same stress, and they come into the emergency room, and you're treating the patient, but you're not treating the family. So sometimes you have to know the dynamics. Otherwise, you're chasing your tail sometimes. So that's just a few ideas. I don't want to talk forever. So any other questions?
Excellent. Dr. Garrison, you're next.
Let me make Dr. Dixon, it makes my heart warm that you seem to have remembered some of that discussion we had on the differential diagnosis of right lower quadrant pain. I really appreciate you for that. But I'd like to just have you switch gears and talk about a couple of other things, some of the common but exotic things that happen when presented to the ER. You're in an urban area, and we know there are these dogs that walk around. How do you deal with people with dog bites or rat bites or stray cat bites? That's, and even people with these snakes and things like that. What's your approach to that? Or even poisons, people that come in with poisoning. And then the second question that I had was, oh God, it blocked. I'm getting old. But if you could just address those things, I think people would like to hear about, what's the incidence of rabies or, in our neighborhood, what's going on with those types of common things that you see that people don't know about.
Okay. You mentioned 15 topics that could easily get a whole day conversation about each of those topics. As
Well,
you
let's
know.
start with dog bites.
Including the dementia that he's getting.
Thanks for the setup.
Oh, the
Thanks for
other
the
thing
setup.
I want you to talk about is your approach to people who come in, male or female, with domestic violence. Yeah, I'm putting you out there, brother.
We only got 30 minutes.
All right, let's just go with dog bites.
Okay,
but I think, Dr. Garrison, if I respectfully, I think your latter subject is more important. Not that any
Okay.
emergency is more important than one, but not just domestic violence, but the sequela of those relationship violence, whether it's child abuse, rape, domestic violence, situations that often will require the preservation of evidence. How do you address that in the ER?
Okay, so sexual assault, as you know, can happen. I'm in the Bronx, and the what's the word I'm looking for? The combination of sexual assault, you can't even imagine what's going on in the Bronx with sexual assault. We have the most common, which is like men causing violence to women. We have, when a woman is pregnant, she's more likely to be abused by her partner. It's kind of weird, right? You have men in relationship with men, and they're coming in complaining of domestic abuse. Okay, you have patients who are identifying as they, or them, and male to female transition, right? And complaining of sexual assault. And you don't know if that patient actually has a new vagina, or is he just a male with male organs still, as Dr. Garrison and others can expand on. So it becomes very complicated. We have two dementia patients in a nursing home. Both of the patients have dementia. And the man went into the room where the woman was, and they found a male on top of the woman, and they both have dementia. So, and they both can't remember what happened. So, and we have to have consent by the victim. We have to have consent before we can do sexual assault kit. And we have to now find out who is the guardian for this patient who's in a dementia in a nursing home. You can't just do a sexual assault kit, even if you saw the assault happen, because that person has a guardian, and the guardian has to consent to that exam. So it becomes very sexual, domestic violence is so complicated. You have to make sure generally that the patient has a safe place to go. Fortunately or unfortunately, physicians, for the most part, have been removed out of a lot of those processes by what they have this new thing called the SANE nurses, which were sexual assault specialist nurses. They're trained to collect samples, because what they found out is us physicians, we were screwing it up. We were screwing it up. We weren't collecting samples the correct way. We weren't documented in the correct way. So thank God for me personally, because I don't have to get involved in a situation. They removed me from the process, because you end up being expert witness for Essex County, for instance, and you have to go in there and testify as an expert witness. And we were screwing it up, honestly. Because first thing we write on the chart is like, patient comes in for alleged sexual assault. They don't want you to put the word alleged on there. Your patient says she was sexually assaulted.
She is sexually assaulted.
Yeah. So,
Mhm.
so it's a very complicated area. It's more a legal area than it is even a medical area. How we get involved is that we examine the patients. If there are no medical emergencies, such as laceration, tears, vaginal tears that we need repair, or fractured bones, or or laceration repair that needs to be done to other parts of the body, we don't get involved. What has changed over the years is patients who come in saying they were choked by their assailant, okay, or choked by their partner, whatever else. 90% of those patients, 95% of those patients, whether you think it or not, they're encouraging you to do a carotid study to make sure there's no injury to the carotids, which is Dr. Garrison could speak more about that. Make sure that we didn't get a carotid dissection or some kind of a carotid injury that we're not detecting. They'd rather catch it earlier than later. And that's the big push that's going on now. I don't know if once the data comes out, how that will pan out, how the algorithm will look, and who actually need to have a carotid dissection study with contrast to see if there's any damage to the carotid or the vascular of the neck. So there's a lot of areas in emergency medicine, but like I said, primarily we've been removed for the most part. Some centers that they don't have the capacity, they will transfer those patients to a sexual assault center. I think Beth Israel and most urban areas are sexual assault centers, but in those smaller communities, they would transfer those patients to somewhere where they can collect the evidence in the correct form. And that would involve what's called a SANE nurse, and usually what they call like almost like a buddy or a partner to help them go through this sexual assault experience and try to lessen the post-traumatic stress that comes with being sexually assaulted.
Excellent.
Um,
Go ahead.
Thank you.
as far as dog bite, because I know Dr. Garrison's very passionate about dog bites. There's two aspects to dog bites, and one aspect is the effects of the dog bite, what it can cause on the body. I will say that we have seen an increase in dog bites since the inception of one particular breed of dogs. Okay. And
Yeah.
And that's the pit bull. And it's not the fact that the pit bull is the aggressor, is how these pit bulls have been trained and raised sometimes by these business proprietors, sometimes in trying to raise these pit bulls to in some of the, and they're in our communities in close proximity to where a dense population of humans are. And eventually you do get these situations. I get it at least once a week, a patient that's been bit by a dog, and 9 times out of 10, it's a pit bull. And these injuries, you should see it when it's an adult, you can try to be understanding that but when it's a child, a 5-year-old child, and you see the mutilation that happened from these animals, you're left to wonder what's going on sometimes. And then they're animals. Animals have instincts that sometimes we can't always control. you step on a dog's tail by accident, you know, he may not mean to bite you, but does that natural instinct just come out to just like, you know? So, but the management of dog bites is interesting. If a dog bite, dog bites and human bites, any bites is not good, as you know. The mouth is the dirtiest part of the body, not just because of the words that come out of our mouth sometimes, but because of the bacteria, the kind of bacteria that festers in our mouth. Um, the mouth is a filthy organ, and all bites should be taken very seriously. Cat bites, dog bites, and human bites should be taken very seriously. Human bites to the hand is almost 95% sure they might have to go to the OR for a washout in a couple of days. Because the mouth is just and the hand is just a small space that the infection gets in there and it blows up so fast that so these guys who punch people in their mouth and they have this teeth mark on their hands, those are very dangerous. They're sure to come back in a couple of days with a real bad infection, of which I'm sure Dr. Garrison has seen in his journey. The other aspect is that we don't usually close real bad dog bites. We don't close those wounds. When I say we don't close them, we may try to approximate them as to so that the patient doesn't lose the form or the structure of that hand. But we don't close them because there's still a lot of infection in those hands that needs to be able to drain out in a open kind of fashion. So it's if it's closed in a very loose manner as to not cause deformity once the wound is healed. And the other aspect of dog bites is does this dog have rabies, which is another big concern. Is this a rabid dog? And I will tell you that Gestalt is the most important thing. You're more likely to get a dog to get rabies from a child being in the attic and getting bitten by something that was flying than you are to get it from a dog. Bats are the biggest carriers of rabies. Not necessarily city dogs. Yeah, okay. A rabid dog is a dog that's been in the wild usually, and has been sick for a long time, walking around panting, his tongue is hanging out. And most of these dogs in these communities, whether it's in the city, these pit bull that bites. That if you get a dog bite, you have to say, was the dog threatened or was the dog being teased? Or if you're teasing a dog and the dog bites you, that's not a dog that has rabies. You know, if you attack the dog's owner and the dog bites you, that's not a dog that has rabies. A dog that has rabies is a sick dog that everyone usually doesn't have an owner. That's been just on the street, a stray dog that bites you. But if you knew you were provoking that dog, and so you have to really tease to the patient, what really happened, was this dog unbothered, or was there, we're playing around? Because that's important, because the treatment for rabies is not a pleasant one. You get like 10 or 15 shots in the wound, and so you need to elicit that. So 90% of my patients, I don't treat them for rabies because I know it's not rabies, but it's a chance you take. And not everyone's going to practice the way I do, but you have to kind of consider the effects. You have to get a good history before you start to just, and then some doctors just get a rabies shot. You're like, I don't care. I'm not, it's my license. I don't want to lose my, so that's very judgmental. Like I said, it all depends on what time of the day you go to the ER and who you see as a doctor.
Okay.
All righty.
The treatment
Dr.
will vary.
Anderson.
The treatment will vary greatly. It depends on who you see. Especially, we speak about Dr. After's talking about chest pain and heart attacks. Some people don't take us seriously. They don't think that we can have heart attacks. And you can see the callus sometimes. I'm like, what are you doing? This guy says he feel like he's having chest pain. He's having chest pain. And you have to.
We have a question that came up. How to avoid disproportionate health burdens faced by Black patients in the ER?
And that's exactly what I was just touching on. Yeah, like I would suggest you go to a provider that worst case scenario, go to a provider that looks like you or who can understand you. And that's hard to find sometimes. That's why going to your primary care doctor is important. He knows you best. But in that emergency, try to go to an area where they're used to seeing people that look like you. you know. Because honestly, some emergency room, you walk in there, they haven't seen somebody look like you in a long time. They don't want to see you. They have their biases. They have the inherent biases about who you are. You can't walk around with a lab coat everywhere you go to be treated with respect. You'd like to know you can go somewhere where you can just go in there with your sweatsuit and they can give you the same treatment they would give someone. But we're just not there in the world yet. So until we're there, you have to, try to go places where people look like you and they can understand you. They're used to seeing people like you, and the doctors are used to actually screwing up people like you with their biases. So I would suggest, urban areas is always good. You want to feel comfortable, but urban areas come with its disadvantages too. It's going to be crowded. It's going to be uncomfortable. But because the emergency room is empty, it doesn't mean you're going to get the best care there. Because it's empty doesn't mean maybe there's a reason why it's empty. you know.
That's true.
So to avoid biases, I mean, I hear this stories all the time. I went to the emergency room. I was having chest pain, and then they told me to go home and drink some Malox. I said, "Did you get an EKG?" No. Some certain basic things you can't always predict who has what. We've learned that. That's why we have these tests sometimes. That's why we have EKG machines. You didn't get an EKG, not even an EKG. No, we didn't get an EKG. He said I was okay. Like, okay, but my emergency room, if you stub your toe, they do an EKG. So.
Yeah. Let me ask you something. We didn't cover. I see a lot of seniors, and a lot of my practice is seniors. And in the ICU, one thing we see a lot of is strokes. And when strokes present to the emergency room, how do we handle them from an emergency? I know once they get up to us, I know what they do in the ICU, but you're on the front lines as far as evaluating somebody, trying to figure out if it's truly a stroke, um, and how much time you have to deal with it so that you can decrease the permanent effects of that stroke. Can you give us some indication?
Yes. Yeah. I can tell you that the stroke management has changed drastically over the last 10 to 15 years. And the reason why it probably has changed because we were probably screwing it up. So now we have these what's called designated stroke center, where certain hospitals are deemed to be stroke centers, and they recommend that patients go to a stroke center. And the reason for that, because people have been screwing it up for a long time. Right? It's just like heart attacks. We have we have heart centers now, where STEMI centers and all that, because we've been screwing it up as physicians. We don't have a set protocol. So stroke centers generally have a set protocol, and they don't vary from the protocol. What is that protocol? Just like the heart, it's a time is brain.
Mhm.
Time is brain, and time is heart muscle. So
Mhm.
when somebody comes and say, and there are certain signs you look for in stroke patients. The number one sign you look for is weakness or numbness, and usually on one side of the body.
Mhm.
Right? That's the primary thing you look for: weakness or numbness on one side of the body.
Mhm.
You also look for sometimes change in speech patterns. Right? And besides change in speech pattern, you look for people who are normally can talk and they're talking garbly. Like, I can't understand. What are you talking? You don't
Mhm.
make sense. You call that loved one on the phone every morning, and you notice you're calling this morning. He's not making any sense, or his memory seems to be lost, or he's stuttering. He never stuttered before, and now he's stuttering. These are all signs of possible somebody who's having a stroke,
Mhm.
or even aggression sometimes. The patient never usually aggressive. All of a sudden, this patient is aggressive. Don't just say think it's a dementia. It could be a stroke,
Mhm.
right? These are all signs of someone who may be experiencing a stroke. And time is of essence. And the tricky thing with strokes when we see it in an emergency room is the time of onset. Unfortunately, heart attacks and strokes, they're more likely to happen early in the morning, 5, 6 o'clock in the morning, and at the catecholamine surge, and that's when you have a lot of strokes. Of course, there's risk factors for stroke, as you know. Um, You have ischemic strokes and you have hemorrhagic strokes. And most people end up having ischemic strokes because of the ills of, coronary artery disease and high cholesterol and all those things.
Yeah,
They
what's an
call that cause
what's an ischemic? Ischemic. What does that mean?
I mean, ischemia is a very general term. It could mean a lot of things. What ischemia basically means is that blood supply to an organ is compromised.
Right.
Dr. Garrison mentioned before about putting that tourniquet on. You put a tourniquet on somebody's arm, you cause ischemia because you cut off the blood supply. Right? That's why he told me to stop telling people to use tourniquets. Right? But also, coronary artery disease or high cholesterol leads to the vessels becoming have formed plaques, and these plaques can narrow the vessel to the point where it becomes ischemic, which means that, it becomes narrow. So when your oxygen demand, when you need more blood to that tissue, it can't move as fast because the garden hose is too tight, and it causes ischemia. You can also get ischemia from exercising. If you do too much rigorous exercise, you can actually cause a physiological ischemia because the supply again, your heart rate is going up to 160, 180, and you're running on a treadmill, and the blood supply is not reaching the tissue as fast as it can. And the result is what? You form chemicals that are excreted, lactic acid or all the other stuff that we don't even talk about here. But that's another form of ischemia. But the ischemia that we're talking about in the stroke is when a plaque from a long-standing cardiovascular disease, and the plaques form, and it causes tissues to not get enough oxygen, and bad enough ischemia, it can actually block off completely, and then tissues die. Brain tissues don't regenerate when they die; they pretty much die. And heart muscle, the same thing. When your heart doesn't get enough blood supply, you get ischemia again from the blood vessels. Those tissues die. Ovarian torsion, when the ovary is torse and the ovary is twisting itself, the blood supply is cut off, you get ischemia, the ovaries die, you can't replace them. So this is what ischemia means generally. Now with stroke patients, they come into the emergency room, you have to decide, did this patient wake up and then was in the kitchen, then they had the stroke, or did they wake up with the stroke? Because the treatment is different for those two different sets of people. Okay, because if the stroke has been happening for an extended period of time, certain drugs you won't use, like the thrombolytics, which is called clot busters. They break up the clots. But if that tissue has been dead for a long period of time, you don't want to use a clot buster. So you want to make sure that you get the history good from the family members. Did the patient wake up with the numbness and weakness? Or did it happen after they woke up? You saw them, they were normal at 9 o'clock, 10 o'clock, you're talking to them, and then at 10:30, you notice a change. Those are two different managements, so you have to be clear on when the stroke happened. And as I said to you before, signs of stroke is usually numbness or weakness, or the patient may even notice the patient's dragging his feet, dragging the leg. You're like, what? Sometimes people are not even aware that they're having a stroke and their behavior has changed, but you have to be in touch with these family members to know that something's not right. Stuttering sometimes, confusion. They're speaking, you can't understand what they're saying. And sometimes the stroke is not as obvious as you think, just weakness or numbness, or you can see if you see facial drooping, these are sometimes obvious sign that something is going on. You don't want to miss those. Okay. Sometimes we think patients have Bell palsy and it's actually a stroke. What does it cause you to do? Bring them to the hospital to make sure we decide if it's a stroke or is it Bell's palsy. So those are very dangerous things too. Yeah.
Yeah. I mean, it's so, yeah, you explained it so well. I mean, as far as the heart is concerned and as far as strokes are concerned, coming into the emergency room, time is of the essence. And I know at our hospital we have a code stroke that they call, or a code for the heart, and the doctors go running down because time is of the essence to make sure that you give the medication to save as much of the brain as you can save from the stroke, and save as much of the heart as you can save, as far as the heart is concerned. So it's so important.
I think, yeah, I just want to say, I think medicine, especially medicine has advanced so much, especially here in New York City, in the US, I guess, with these stroke centers, with these STEMI activations where STEMI mean ST elevation myocardial infarction, which basically means you look at the EKG and you see obvious signs that somebody may be having a heart attack. There's a protocol in place, and you want to get that patient to the cath lab. In the case of a heart attack, you want to get them to the cath lab in less than 90 minutes. That's the goal to save heart tissue. And most of these heart centers do very well when they have these protocols in place. Same thing with the strokes. The reason why we have this in place is so we can have the CAT scan available, so we can look at the CAT scan and tell if this patient having an obvious stroke or if the patient needs to have further. And another aspect of a stroke that people don't understand is dizziness. Patients walking and they're lightheaded, dizzy, and they're not walking normally. They look like they're confused. That term dizzy is a very misleading term. You know, somebody's lightheaded and dizzy, they could be having vertigo, or just the ear. It could be an issue of the ears, or it could be an issue of the brain or the cerebellum or the back of the brain where their balance is off. So if you notice somebody is walking and they feel like the wall is falling down, and they don't just think the person's giddy or dizzy, or they could be having a stroke. And if you go to the wrong center, or like I said, they can do a CAT scan. And because a CAT scan is negative, they think you're out of the woods. You actually need an MRI of the posterior brain to look at the cerebellum to make sure that they're not having an ischemic stroke in the cerebellum. The CAT scan is not good at looking at the cerebellum and posterior strokes.
Yeah, I know we in the ICU, we often do MRIs as far as strokes are concerned, and and a negative CAT scan, and the MRI will give us the diagnosis. Just to give you an example, there was a patient recently that came in for some pulmonary problems, and during the hospital stay, he had decreased vision in one of his eyes, and on the same side of the face, he had a drooping of that facial on that same side, and we had to diagnose whether it's a stroke or not at that particular point. So, it can happen anywhere at any time, and you have to be astute to recognize it and go forward as far as the treatment is concerned. With ultrasound, um, uh, I know one of the things from a pulmonary standpoint we deal with is pleural effusions. And, a lot of times the pleural effusions is quite massive. Sometimes, and maybe I should explain what a pleural effusion is. It's a situation where you have fluid between the lung and the chest wall, and you have your chest wall and you have your lung, and usually they abut each other, and you don't have any fluid. Well, put it this way, you have very little fluid between the two, and it's just enough fluid to keep it moist. But what happens sometimes for certain situations, fluid builds between that space, and if this is the lung, it pushes the lung away from that chest wall. And when that happens, there's only so much space in the chest cavity. It pushes the heart over, and it pushes the other lung. It compresses on the other lung. That happens. Well, I'm biased because I'm pulmonary, but it happens fairly often. But how do you deal with that situation? I know your ultrasound can probably help as far as diagnosing it, but what do you guys do in the ER when you come in with massive pleural effusion? A lot of times it's secondary to lung cancer or lung mets and lung cancer. So, and there are other times it could be due to patients not appropriately being dialyzed and they build the fluid over time, or sometimes even heart failure. I've had heart failure patients that have come in with really large pleural effusions, and even pleural effusions on one side, believe it or not. Usually you would think it's on both sides with heart failure, but unilateral pleural effusion secondary to heart failure that we have to tap periodically. So how do you deal with that in the ER?
Like I said, I'm in a busy urban area, so we have all the specialists there. But if I was in a community and somebody came in at obvious distress, respiratory distress, you do an X-ray. Usually, you do an X-ray, and you'll see one side of the screen is whited out. You know, X-ray is supposed to look black, and now this area looks white. You suspect an infusion, so you can either go do a CAT scan, or what we do in the emergency room these days is we do the ultrasound, and we could put the ultrasound even on the patient's back or on the side. You will see this large amount of fluid, and you can actually do what's called thoracentesis, where you go into the pleural space, usually from the back, approach it from the back, and you could put a needle. And before they used to do it blindly, where they would count eight, eight intercostal spaces, and they go posteriorly, and they can put the needle in there, and they can get the fluid off. But now everything is ultrasound guided. We see the pocket of fluid, so we cheat with ultrasound. We see the pocket of fluid, we just go in there and we approach it, in a sterile fashion, and we pull off the fluid. Sometimes you can pull off 900 cc's. A lot of fluid can collect in that space, and the patients usually they get instant relief once you pull the fluid off. But you also have to be mindful that there's a reason why the fluid has accumulated, and it's usually beyond the scope of emergency medicine. They get admitted. They have a lot of diagnostic tests that's performed on the fluid to determine, number one, is it a cancerous fluid? Is it just is this like just the different types of fluid that can cause different kind of, is it just an unconic pressure issue, or is it just more like a cancer or something?
Right, right. All righty. Um,
Excellent.
oh, all right. The thing of it is that, yeah, and that's my specialty. So, I think about that all the time, and how ultrasound can help, and what we need to do as far as appropriately diagnosing. And you hit it right on the head. You do the thoracentesis, what is sticking a little catheter in through a needle, take the needle out, leave the catheter in, and then just draw the fluid out, and then repeat the chest X-ray, and that patient will feel relief immediately, because that lung is able to expand and open up, and now it can take air and give oxygen to the blood.
I'm sure Dr.
Go ahead.
Dr. Anderson could probably expand on that area also. His patients who have ovarian cancer, they often come in with fluid in the abdomen also. And while he's able to pull the fluid off, like I said, oftentimes the fluid will accumulate again, but it would still give that patient enough relief, where their quality of life can be improved, while they struggle with the other effects of the cancer.
One question.
Oh, yeah. This anyone else have any final words? Because we've come to
I
a
have one
point
question.
where, go ahead, Dr. Court.
Has
Dr.
Dr.
Court,
Dixon
Dr.
had,
Court, Dr. Court, you want to know why I'm not coming back to Guyana anymore, right?
yes, you promised me that you will come at some time, so we still hold you to that. Right. Have you had any instance where you had to do this in reference to the heart? That there's so much fluid in the heart that everything is compromised, where in an emergency setting, you've had to put a needle in the pericardial space, or that's too dangerous.
No, no. Unfortunately, where I work, it's not for the timid. So I've done thoracotomies. I've done 4 thoracotomies in the Bronx since I've been there. Um, my first thoracotomy I was involved in was at University Hospital in Newark. Where what's a thoracotomy? A thoracotomy is like if somebody gets stabbed in the chest, and you have to actually go in there and suture the heart, or you have to go in there and staple the heart. You have to kind of stop the bleed. So when I was at university, actually, my first thoracotomy was with Kevin Clark. So, uh, Kevin Clark and I, Kevin was a senior resident then, and I was working as a early resident. Kevin was the only one. He was in charge, because the attending was in the OR with another patient, because you know how universities, you get multiple traumas at one time. And Kevin and Dr. Kim, Jeff Kim, they were there, and I was able to use the ultrasound to tell them there was fluid around the heart. So Kevin and they did a thoracotomy. I was able to observe that thoracotomy as a front seat onlooker there, not knowing that I would do 4 more thoracotomies at Jacoby in the Bronx, where we get a lot of patients that come in, the protocol is if somebody comes in the trauma comes in and they lose pulse within 10 minutes of coming to the emergency room, you should do a thoracotomy. Most doctors won't do it because they're just not comfortable doing it. But the only thing that makes you comfortable doing something is to just do it. And usually if they come in within 10 minutes, the trauma surgeon, it takes them a while to get downstairs. So I have to be the first person to do the thoracotomy. So I'll make the incisions and I'll expose the heart, and I would actually have to suture the heart sometimes or staple the heart, try to find the bleed. If I can't find the bleed, first of all, what I would have to do is kind of like try and see if I can identify where the main vessel that feeds the heart is, and we have to clamp it. And we clamp it in the thorax because we want to make sure the brain is preserved of oxygen. So we clamp the main vessels to the extremities in hopes of preserving the brain and those organs. And we actually give the patient lots of blood while we try to stop the bleed. So I've been involved in 4 of those cases. Actually, the one that Kevin and I did, that patient survived. He actually walked out the hospital. He was stabbed in the chest. If they're stabbed, they survive, have a higher chance of surviving. If there's a gunshot wound, it's usually through and through, and those are much harder to repair. They usually exsanguinate before we can actually do what we have to do.
Excellent, excellent. All righty. So I'm telling you, this has been a very engaging Doctor's Lounge. This has been one of the highlights to get someone like you in that we don't hear about this often, and the public should know about the emergency room because that's the first, that's the first entrance into, whether I'm going to do well, whether I'm going to, can they diagnose what's wrong with me? What type of medicine will I take? What type of person I'll meet there? Will they really be patient with me to allow me to tell them my story and what's going on with me? Can they truly diagnose it? So it's important to understand the emergency room. I think all of us should. And I appreciate you, Dr. Dixon, coming on. We're going to get you back. We're going to try to make you part of the panel, actually, if you have some time, because I think that you can add to many things that we discuss here on the Doctor's Lounge. So once
Well,
again,
I appreciate you guys bringing me back into the fold. It's been a while,
it's been a while, brother. You got to come home. All
Well,
righty.
the truth of the matter is he never really left home. I think he spent more time in my office in the last 2 weeks than he's been
That's right.
in the hospital.
Like I tell you, when it comes down to it, you got to know who you're going to as your doctor. You have to know who knows what and who's going to do what. So I'm fortunate that I know, and I've never left the tribe, so to speak.
All righty. Excellent, brother. Excellent. Well, as usual, we've come to an end in our closing remarks. Number one, I'd like to thank OBHealthy for allowing us to bring this webinar to you. You check out OBHealthy, their total health network. It's just so much on that website that's health generated. So just go and check it out. Secondly, we are here every second Saturday of the month. Please tell friends and family, and check out our past webinars. Just go to OBHealthy and hit the YouTube sign. All of our past webinars are there. It's so easy to access, and it's so important because we hit so many topics. And remember, it's caring and sharing, so let others know. And the most important thing that I can say, I say this all the time, please do not change any aspect of your medical care until you consult your physician, because only your doctor, truly only your doctor, can best treat you from a medical standpoint. All righty. And that is it until next month. And as I stated, I'm going to try to twist Dr. Garrison's arm to bestow some knowledge on us next month. We shall see if he comes through, or we will have another topic. So check the website. You'll see what topic it's going to be. And until then, peace. And Dr. Dixon, one more time, thank you. Thank you. Thank you. Until next time, peace, everyone. I'll see y'all later next month. Same
You're
time.
welcome. Thanks for having me. Appreciate it.
Yes, yes, definitely. All right. Take care, everyone.